Welcome to our presentation this morning. This morning's topic is electronic medical records in Western Jamaica. Now, before we delve further into this presentation, I'd like to provide some context as to my background in leading the development that led to this presentation. I'm a graduate of the University of the West Indies, a class of 1999, and I completed my internship at the Cornwall Regional Hospital. In 2009, I entered the mobile app development space where I designed the first mobile app for communication with doctors and patients. The interface was submitted for patent protection, and the app was subsequently published to the App Store in 2011. In 2012, I completed my dual certification as a healthcare privacy and security professional. Now, this certification provided in-depth training on HIPAA compliance and the technical standards governing the storage, use, and access of patients' protected health information. This training also qualified me to design, develop, and implement healthcare privacy and security protocols for large organizations. In 2015, I completed my healthcare MBA from the George Washington University. My professional focus there was on health information systems, electronic medical records, and social entrepreneurship. In 2016, I launched the first telemedicine portal in Jamaica in the form of Express Health. Since then, I have successfully integrated several rural hospitals, comprehensive clinics, pharmacies, and private doctors' offices onto the interface. Over the last several years, I've spent my time contributing my skills and expertise through membership in organizations such as the Health Information Management System Society, the American Health Information Management Association, the Identity Management Task Force, and the American Telemedicine Association. In addition to these involvements, the majority of my time has been spent as software development lead and project manager for the various iterations of the interface to be introduced during this presentation. So having provided a brief overview of my background, let us now move to the topic at hand. Electronic medical records in Western Jamaica, integrating tertiary specialist hospitals with satellite referring centers to reduce in-hospital burden in the COVID-19 pandemic and beyond. This topic is currently of pivotal import and applies to all other jurisdictions within Jamaica and the Caribbean. The history of the disastrous consequences of poor implementations of EMR systems in the United States must be instructive to us in Jamaica and in the wider Caribbean. These failures were related to three main factors. Firstly, there was very poor workflow virtualization, and this resulted from the little attention given to the critical factors of how the physician carried out his task. This led to poor implementation of the software and a disrupted workflow for physicians that made life difficult and actually decreased patient satisfaction. Secondly, there was a lack of physician involvement in the development process. Most EMR developers are software developers with little insight into the final impact of the system. The systems were therefore not designed to impact the real world. And finally, the use of proprietary software that provided no APIs, no interoperability, and no scope for third-party expansion was the single most detrimental factor that created information silos that restricted the sharing of patient health information between facilities and between providers. The solution to this third mistake was the most costly. Having learned these lessons from the Americans, it is imperative that we don't repeat the mistakes that their history has taught us. The history of our own Vision 2030 mandate is therefore of significance. Vision 2030 identified the need for a referral network that facilitates referrals within and without the public health sector. Vision 2030 also spoke to a requirement for a robust legislative and policy framework to ensure success. It is my view that a robust policy framework must be driven at the local implementation level and must be led by physicians. In order for this leadership to take place, physicians must have clear insights into the problems we need to solve to make our health systems better and have a full understanding of the benefits of the solutions proposed. The problems we face are not new, and we certainly will not be the first to propose solutions. However, in creating our solutions, we have recognized the workflow imperative of physicians, the benefits to patients, and the need for care coordination as the main drivers of our effort. In the broadest terms, we have limited resource capacity, both in respect of human capital and the technical capacity required to make this thing work well. Secondly, we have a deadly disease that is easily transmitted and therefore places our healthcare delivery environment at significant risk. We have an archaic referral system that does not inspire efficiency and is a significant inconvenience and sometimes even a health risk to our patients. Finally, there's poor care coordination due to the limited communication systems that exist within our current healthcare network. So what are the solutions we envision for these problems? At a minimum, the solutions have to be matched to the problems identified. Firstly, we require more efficient use of our limited resources with the implementation of systems that will maximize our collective productivity. Secondly, we need to limit the gathering of patients in the hospital and clinic environs. Thirdly, we need to implement an online referral system that allows for seamless referrals between colleagues in the public and private sectors alike. And finally, we need to focus on improving our communication systems to ensure proper care coordination. Now, having said that, we require a host of tools to achieve these solutions. These tools must include a global appointment system that manages resource availability in both the public and private sector, a referral system that allows both internal and external referrals between public sector and private sector physicians and allied colleagues. We need an electronic medical record system that is purposeful in supporting meaningful workflow enhancement. We need a telemedicine portal to support remote patient monitoring and also support collaboration of the healthcare team. We need an e-request system for prescriptions, laboratory, and radiology services. And finally, we need a robust data analytics layer that will create the research opportunities that would guide health policy and inform treatment protocols. Our healthcare management system provides all these tools. Let's take a look at that. Let us look now on the appointment system. To make the appointment system truly functional, we attach certain properties that will serve a direct real-life purpose in improving the care delivery experience. In setting up the appointment, providers are required to assign a duration, which will automate the provider's capacity planning. They must provide a location, and this location will help to direct the patient to the care delivery site or the clinic without the need for asking for assistance, thereby reducing their interaction with members of the hospital or clinic staff. The service being provided and its properties. Now, this service, when we're looking at creating our service, we have to then ask ourselves some questions. Can this service be booked by the general public, or is it just limited to healthcare providers? Does this appointment require review and approval before confirmation, or is it automatically confirmed once booked? Is the service delivered to a batch of patients at a particular time, or is it delivered to individual patients? Is the service dependent on a particular person or resource constraint? For example, such a resource constraint could be a particular room in which the service is delivered. Capturing these properties allows the appointment system to reflect the real-world operations of the healthcare providers represented within the system. And this we thought was of paramount importance, as for the most part, these logistics are not usually captured in systems that are developed for healthcare. Now, in the list of appointments displayed for the Percy Junior Hospital, you will note, for example, that the general wellness visit does not require prior approval, whilst all other clinic appointments require prior approval from the clinic physician. You'd also note the varying durations of each appointment type, with a major 2 surgery being 150 minutes, while the anesthetic clinic review is only 15 minutes. So these are the ways we capture our real-world activities so that can be matched for us by the software and therefore manage our real availabilities in our clinics and in our hospitals. Now, with a functional appointment system, providers and medical record staff can get direct insights into the appointments booked for a particular clinic by simply choosing the clinic type from the drop-down list of all the clinics created. Having chosen the SOPD clinic for the date captioned, a list of all appointments will be displayed for perusal. Now, attached to each referral is a view button used to review the details of the referral associated with that particular clinic appointment. While viewing the particular referral, the built-in point of access system will allow the nurse in clinic, for example, to provide a real-time log of the patient's interaction with the clinic. Has a patient arrived? Is he or she a no-show? Are we rescheduling the appointments because of internal reasons or otherwise? Are we simply canceling this appointment because the patient should be in another clinic? Again, the system captures the required workflow of the staff involved in this care delivery process. Now, within the context of the COVID-19 pandemic and beyond, the appointment system allows for crowd control within the healthcare delivery environments. Patients are assigned to batches and the patient app displays their appointment entry times. Security officers will only allow entry to patients designated for particular entry times. This design was in keeping with the just-in-time concept of supply chain management. With this implementation, patients will have minimal wait times within the hospital environment and therefore create a lower risk of exposure to themselves, others, and to our staff. The referral system is directly built onto the availabilities created through the appointment system, and they provide a synchronization between the intent of the referring physician and the availability of the service provided by the accepting physician. This will then serve as the nexus of a proper care coordination system. The referral system is a global referral system that allows each physician access to all other physicians authorized within the system. This will include regional, international, and global colleagues. The ability to find and connect with colleagues is made much easier by the search parameters available to our physicians. Physicians may search by name, by specialty, and even by the facility or the location. This system provides physicians with a direct connection to their colleagues to ensure accurate referrals. The referral process is made manageable by the physicians creating a favorites list derived from the search results. From his favorites list, the physician will choose the target provider. He will then choose the location that the service is required. This is relevant because a GP, for example, might be referring a patient to a consultant. If the patient is being referred publicly, then the hospital location would be chosen. If the patient is, however, being referred privately, then the consultant's office location would be chosen. Once a location is chosen, then the actual service required is selected. This service could, for example, be a new SOPD clinic appointment for a patient being referred with a hernia or an orthopedic clinic appointment for a patient with a fracture. This targeted approach to the referrals facilitates the coordination of the patient's care needs. In this example, the SOPD new clinic is chosen. The available days for this clinic is displayed, and those days that are unavailable are blocked. The referring provider will therefore select and approve available day. Once this day and date is selected, the appointment times are made available. The referring provider may then select the time and book the appointment by entering the details for the referral. The patient demographics are first entered or pulled from the database, and the referral information is entered into the appointment request. The referral can then be sent, and the referring physician could immediately tell his patient the date and time for their clinic appointment and the name of the receiving physician. There would be no need to travel to the hospital unnecessarily to book an appointment at the medical records department. And this is critical for us during this time of the pandemic, where we need to be able to provide the services without necessarily having the one-on-one interactions. Now, instead of this patient traveling to the medical records department, the medical records department will now operate with greater efficiency. Staff would have greater insights into all clinic appointments, including the appointment just booked in the previous example. Additionally, the clerks would have the ability to book the usual walk-ins into the respective clinics through their own dashboard. They could reschedule appointments as allowed by the clinic and provide hard copy printouts of expected clinic attendance to support services, such as the services provided by our security officers, who would then have responsibility for allowing people into the facility. Now, the staggering cost to individuals in respect of time, money, and convenience as a result of a lost or forgotten request form or prescription is too often uncalculated, and it is significant. The efficiency achieved by our e-request system is measurable and is very significant. Now, electronic prescription requests are sent to any pharmacy of the physician's or patient's choosing. The system also sends a copy of the prescription to the patient. Physicians are able to create favorite medications lists according to their own prescribing habits. Now, a pharmacy management system is also integrated for the pharmacist to manage a prescription request received. The pharmacist may fill the prescription, do a partial fill, or transfer the script to another pharmacy. The prescription request will show all quantities required to be dispensed. The prescription may be partially filled or completed according to availability. A log is created for prescriptions that are processed, with a record of the amounts dispensed. If partially filled, as in the example above, the pharmacist may transfer the request to a colleague pharmacist for completion. The patient could then be redirected to the pharmacy as necessary. This system creates a permanent audit trail for all stakeholders: the pharmacy council, the pharmacy owners, the patients, the physicians, and the payer, who in this case could be either an insurance company or the NHF, as in the case of our chronic disease patients. Similar systems have been created for the electronic request for lab studies. With the required diagnoses as a prerequisite for this submission, the system is fully supported by the updated ICD-10 diagnostic codes, and these codes are required for integration with insurance systems and other billing systems. Likewise, electronic requests for radiology studies are also supported by the ICD-10 diagnostic codes. Requests are directed to the chosen facility, and a copy of the request is also sent to the patient electronically. With respect to telemedicine and what is required for the telemedicine portal, our view of telemedicine has progressed from the mere connection offered by video conferencing to ensuring a tightly integrated interface that will allow for asynchronous communication. The asynchronous nature of text communications and electronic requests are what will drive improved efficiencies in healthcare. Our telemedicine portal embodies these benefits. Our patient mobile app is equipped to have patients interact with us in real time to request prescriptions, manage their appointments, and access various physician-supplied health resources. In addition, patients benefit from medication reminders to improve treatment compliance and other health reminders to improve self-care. Our solution is impactful and very easy to use. A specific feature that is most significant for the COVID-19 pandemic is the ability for patients to find clinic locations based on their appointments. Additionally, they are able to search for testing sites and other healthcare facilities depending on their need. Our provider solutions are geared at allowing physicians to manage their healthcare workflows. This will include things like accepting chats from patients and colleagues, creating e-prescriptions, managing appointments and scheduling their own availabilities, managing team members, assigning these team members to their various responsibilities. For example, a team member physician could be assigned to run a particular clinic, so that these assignments will allow for these physicians to know exactly what their clinic load would be for a particular date so that they could plan accordingly. Our electronic medical records implementation is geared at a purposeful collection and use of patient data. Each dashboard will grow to reflect the specific needs of the respective specialty and will provide a requisite decision support. Thus, these dashboards will go through the consultative process between physicians based on our needs and what we hope to achieve. Our metabolic dashboard is geared at the management of chronic illnesses such as diabetes mellitus and hypertension. By entering patient clinical data, decision support algorithms will provide insights into such parameters as a patient's 1-month weight goal, their risk profile, their average basal energy expenditure, and much more. These advanced decision support functionalities will improve patient outcome and help doctors to do much better in how they deliver their care. This is what we mean by having an EMR that is purposeful and is based on assisting doctors with their workflow and improving our decision support. Now, the primacy of the physician's role in the approval of patients for receiving an NHF card supports our own view of virtualizing the application process. We find the current workflow to be onerous and even less desirable during a pandemic. Currently, a patient gets a form, let's say at a pharmacy. He then fills the form out. He goes to the physician's office. The physician signs and fills the form. The patient takes the form back to a recognized center in the Western region, Cornwall Regional, for example. A clerk reviews the form and submits the information. The patient then awaits the arrival of the card. We believe that the patient experience should be enhanced by substituting the current workflow with the physician completing and submitting the form online. The patient would be immediately authenticated for NHF benefits, and little interaction would be required otherwise. As mentioned earlier, the collection of data within the interface is purposeful and related to supporting improved patient outcomes and enhanced provider workflows. The research potential using the collected data is enormous, with the added ability to create specific research dashboards as required. In addition, our advanced data analytics layer provides additional insights. Broadly, the data analytics potential provides advances in 3 specific areas. Firstly, population data analysis will yield trends that could guide public health interventions and public policies. Secondly, analysis of disease-level data will lead incidence, prevalence, complications, and even additional new insights into the disease process. Thirdly, treatment and outcomes data anchored by a robust ICD-10 diagnostic designation will provide comparative effectiveness analyses of the various treatment methods that could guide further treatment protocols or even determine for the NHF the value of keeping a particular medication in its covered status. These are important things to use data to assist with, and we believe that with our data analytics layer, we would be able to achieve these benefits. To summarize, an implementation of this system would achieve several key benefits, not the least of which will be 1. An organization of the clinic scheduling, 2. Clear visibility into the current appointments, 3. A reduction in overcrowding and a measured control of patient movement within the hospital environs, 4. Automated patient communications to effect compliance, 5. Remote communications with and monitoring of patients, 6. E-requests to include prescriptions, labs, and radiology, 7. A purposeful EMR system that helps with our workflow, and 8. An advanced level of research and data analytics capabilities. At this point, we now ask that you consider the implementation of this system in the secondary and tertiary institutions within your region. The staff will then be remotely trained to use the interface. Then the final step would be to integrate satellite hospitals and clinics into the network. The system is indeed live. In closing, I'd like to recognize the contributions of several strategic partners who have been a part of our decades-long journey to this point since we started in 2010. Walters Clear Health for providing support for physician CMEs and decision support workflow. The Amazon Web Services HIPAA team for providing the most secure and first HIPAA-compliant cloud hosting environment for healthcare data. Plexus Health for providing insurance adjudication support for online health insurance processing. Ava Informatics for leading the way in healthcare data analytics and showing us how. The Intellisoft Group for providing the guiding workflows necessary for online onboarding and credentialing of physicians and allied health personnel. The George Washington University Medical Faculty Associates. These unsung heroes are the world's leading provider of telemedicine, with support for over 90% of all U.S. vessels at sea. I'm humbled to have spent time learning from the best during my tenure. And finally, to my Express Health team, a dedicated and relentless group of healthcare developers whose million lines of code have created an interface that truly has transformed healthcare delivery. Thank you all so very much. Colleagues, I thank you for taking the time to listen. This has been a presentation by Dr. Shaun Jones for Regional Healthcare Services, delivering tomorrow's healthcare solutions today. Thank you.